All right, party people. Today, we're going to be covering peripheral arterial disease. And this, for USMLE, refers to atherosclerosis of the peripheral arteries, primarily in the legs. This is commonly due to diabetes, smoking, and hypertension. So you'll often be told that patients have non-palpable or 1+ dorsalis pedis or posterior tibial pulses. For reference, 2+ to 4+ pulses are normal. 4+ is brisk, but still considered normal. Don't overthink this. Diminished peripheral pulses are a hallmark of peripheral arterial disease. In the lower legs, you may see trophic changes like shiny, hairless, what is referred to as glabrose skin. This specifically references the loss of hair on the legs, and this is a diagnostic clue. You should be able to recognize arterial ulcers, which appear as punched out small ulcers on the feet and toes. In contrast, venous ulcers are large and sloughy. These are located near the ankles. Here are two images to compare and contrast. You have to be able to spot recognize these to understand what it is that you're dealing with. Now, high yield for arterial disease for USMLE. When we talk about ankle brachial index, this is the first diagnostic step for peripheral arterial disease. You compare the blood pressure in the leg to the pressure in the arm. An ABI less than 0.9 is diagnostic for PAD, peripheral arterial disease. This indicating reduced blood pressure in the leg due to arterial narrowing. The USMLE can give you a question where ultrasound is listed instead of ankle brachial index. So most of the time, the vast majority of the time, ABI will be correct. However, you also have to know that ultrasound can be another option. Now, what will never be a correct first step will be angiography. So just forget about that completely as a first initial diagnosis or diagnostic tool. So what they may do, you may get a patient with intermittent claudication. Think of arterial disease. This is the first step, which would result in ABI. If the ABI is already given to you at, let's say, an ABI of 0.5, the next step is an exercise stress test to determine tolerance. If they don't give you the option of exercise stress test, then you prescribe a walking/exercise program. Now, exercise stress test will be the next best step at least half the time. If it's not there, look for the walking program or exercise prescription. Also, cilostazol, a phosphodiesterase inhibitor, and arterial vasodilator can be used only after the patient is already on a walking program. Don't choose this as initial therapy. If they give you a patient who's already on a walking program yet still suffering and ask which drug could help alleviate his symptoms, cilostazol is correct. Now, surgery such as angioplasty, stenting, endarterectomies, bypass usually is not tested. And that's usually reserved for advanced real-life cases. Now, in terms of medical management, they're going to give you a triad. It's the exact same one that you'll see for carotid stenosis management. That is an ACE inhibitor/ARB. Usually what you'll see is lisinopril, a statin. It doesn't matter which one, low or high intensity, they don't really get into it. And antiplatelet therapy, which is basically almost always aspirin. So what they can do is can give you a situation where they give you 2 out of the 3 and ask which one is missing. Or if they give you all 3 are listed and they ask what's the best next step, and you can say no change is necessary. So for example, if they give you a patient and he's on lisinopril and statin and they say what else could you add, then you'd say aspirin. On the flip side, if they said he's on lisinopril and aspirin, what is missing, you'd say give a statin, and so forth. Or if the patient's already on all 3 of them, how should you adjust his treatment? The correct answer would literally be no change necessary. All right, that's it for this one. Go crush it.